What do the fellows think? Are there more fellows that will be signing on?
Who's there?
There's maybe one or two more, but we can get started. I think there's a new ECMO coming. I think it's tying up a few people. So I think why don't we get started, and hopefully the last two or three people jumping on will join in.
Okay, yes.
Okay, so whenever you want me to start, or?
I think so.
Yeah, I think we can start. Yeah.
Okay. All right. So hi everyone, and thank you again, Anna Marie and Effie, for having me give the talk. And of course, at any time anyone has a question, please don't hesitate to just interrupt me, and I'll try to answer as best as I can. So today we'll take a journey down the windpipe, I guess the kids call it, through the airways, and we'll begin with the trachea, and then we'll end into the alveolar sac, and we'll try to go through some of the conditions that affect the airways. And I've broken them down into three main compartments: the one that involves the trachea, bronchi, and then the small airways. As you know, the airways are often ignored by a lot of people because they're often not visible on a chest X-ray, or even if there is an abnormality, often they're overlooked. And certainly bronchi and small airways are not visible. So often individuals with airway abnormalities end up kind of bouncing around, or maybe get diagnosed. There's always a delay in the diagnosis. CT is really the test of choice to evaluate the airways. And if there is anything that you can get from this talk today, and forget about all the diseases and whatever, it is that you make a conscious effort to look at the area from the very top of the image to the bottom. So always on every study, what I do is, before I even look at the lung parenchyma, I start with the trachea, the bronchi, and go as far as I can into both lungs to make sure that I have inspected the bronchi and the trachea. And I think once you do that and you get into the habit, I think it will help you, and you won't miss abnormalities involving the areas. And plus, it will help you, especially if you were going to go do a bronchoscopy, because it'll give you a nice landmark about where the finding is and how to get there. So CT is really the test of choice. Most of the time, we just do a routine chest CT. But if there are certain aspects of pathology involving the trachea or the small airways, then you may need to do additional special images. And there are two particular ones. If it involves the trachea, we call this what is called a dynamic expiratory scan. So let me explain. So normally, the patient lies down on the CT table. We tell them, take a deep breath in, hold it, and then we image their chest. A dynamic expiratory scan is one where we tell them, take a deep breath, but as you're expiring the air, as you're blowing the air out actively, that's when we image their trachea. So take a deep breath. As they're blowing, we image their trachea. So the purpose of this is that the trachea, when you're taking a deep breath, the shape of the airway is not going to be affected, but it is during expiration, when there is increased pressure in the thoracic cavity, that the trachea may collapse or do something to its structure. And so you want to image during that phase. And so when they're actively expiring the air, we image, and then we can see if there is any pathology. And I'll show you some examples. The second type of scan is the end expiratory scan. So that is, now you're taking a deep breath, you let the air out, and we tell the patient, hold it now. And that's end expiratory scan. What will that show? It will show that normally when you're taking a deep breath and you let it out, like a balloon, air was in there, you pop the balloon, air comes out. But if there are airways that are, and I'll show you examples, that are affected by disease, then distal to them, you may see persistent lucency or air trapping. So this sequence or technique of images will demonstrate that or accentuate the finding. So normally it is just taking a deep breath scan, but if you're looking specifically for tracheal diseases and small airways, then you may do one or the other imaging. It is always important in radiology to know the anatomy at the microscopic level because it will help explain a lot of the conditions. So here's a CT image of the trachea. These are the three great vessels of the arising from the aorta. Esophagus is here. A normal trachea should normally be kind of oval in shape. You may see calcification of its cartilage, you may not, depending on the age of the individual. And of course, the posterior portion does not have the cartilage, so it will not be calcified. An illustration here shows you the appearance of the trachea, typically oval in shape. The most inner aspect, as you know, is the mucosa of the trachea. Underneath that is the submucosa, which is where you have salivary glands. And you also have the tracheal cartilage, which is a horseshoe-shaped ring, which is present along the anterior and the lateral aspects, but it is not present in the posterior aspect. And then you have the adventitia outside. So when you're taking a deep breath, often the posterior membrane bulges out. When you expire, the posterior membrane bulges in. And you can look for those on the scans to help you determine, whether the patient followed the instructions, whether the study was good or not, and so forth. Okay, so we have now a little understanding about the shape of the trachea and what it is made up of. So let's look at some conditions. So tracheal diseases can be broken down into two big categories. You can have narrowing, which can either be focal or it can be diffuse. If it is focal, we usually talk about malignancy. If it is diffuse, we lump some into this big category called inflammatory conditions. And then there is one condition where the trachea can be very big and dilated, and I'll show you example of that. Tracheal narrowing or stenosis can then be broken down, as I mentioned, into two parts, malignancy and inflammatory conditions. In the malignancy category, which are kind of rare, we don't see too many of them, but probably the most common is squamous, next best is adenoid, and then you have some rare tumors, and then metastasis. And we'll talk about the inflammatory conditions in a minute. As I stated earlier, squamous and adenoid account for majority of the tracheal tumors. They can present as polypoid, sessile lesions, or circumferential thickening, and I'll go over the images. Metastasis from hematogenous spread is very rare, but most of the time you will get extension of tumor from adjacent organs like the lung, the esophagus, and the thyroid that can involve the trachea. So that is more common that we see in our everyday practice. So as I mentioned, tracheal metastases are rare. Local spread from adjacent organs like the lung, esophagus, thyroid are much more common. Hematogenous spread is pretty rare. We'll see it maybe once a year or so, I guess. So see, this is radiology. I'm going to show you a lot of images. And so just sit back and enjoy. So here's a patient who has the CT of the chest. We gave intravenous contrast. So this is the aorta. These are what we call soft tissue windows. So the lungs, we're not looking at the lungs here, but we can see that aorta, here's the nasogastric tube in the esophagus. This is the trachea. Instead of being nice and dark, filled with air, there is an isodense lesion within it. that's protruding into the lumen. Okay, and very hard to tell what it is, but in this individual who was a smoker, we thought it was going to be a squamous cell, and we biopsied, and that's what a squamous cell carcinoma of the trachea will look like. They tend to arise from the mucosa, so when they do grow, they protrude into the lumen of the airway and will kind of occupy it. Here is a different patient. This is what a normal airway looks like, a little calcification of its cartilage. Posterior membrane is bowed forward, so a patient is a little bit in expiration. And then you can see that there is a large endoluminal filling defect. Icidens, you can see that it is just like tissue. It's not mucus or anything like that. And this is another example of a patient with squamous cell carcinoma. So, they are the most common primary tumors. They are related history associated with smoking, and they are aggressive, and they do have a poor prognosis. And we don't see them that often, but you will see them every now and then. And those are a couple of examples of squamous cell. As opposed to this patient, and as I mentioned earlier, on the X-rays, imaging of and evaluation of the airways is very limited, but it is always important for us in the pulmonary world to always inspect the airway. If you will get into the habit, then every now and then you will see that here's the trachea, and here's the right main bronchus, and then left, but you can see that there is a filling defect in the distal trachea extending into the left main stem bronchus. Not the prettiest image, but you can kind of make out. On CT, you can see that it's a non-contrast CT. This is the ascending aorta, descending aorta. Here's the esophagus in the back. And then in the airway, in the trachea, you can see that there is this large filling defect. Now, as opposed to the other case that I showed you, you can see that this lesion is now growing into the wall of the trachea or the airway. You can see how it is sort of growing. And this is a classic appearance and behavior of this lesion. When you see tumor arising in the trachea and it is growing within its wall, then we tend to think that it is most likely going to be a tumor that's arising in the submucosal region. And the first thing that one would think about would be adenoid cystic carcinoma. As I mentioned earlier, if you have a lesion arising from the mucosa, like squamous cell, they'll tend to protrude into the lumen, but they are not going to demonstrate growth within the submucosal gland. That would be pretty unusual. Adenoid cystic carcinoma almost always will give you that sort of clue that, yeah, if it's growing in the wall, it's going to be adenoid cystic. Here's some multiplanar imaging. They're not that helpful. They look pretty, but since it's a conference talk, I tend to kind of put it together. I don't find it as helpful, but it does look kind of fancy. So here's the trachea, and you can see this large filling defect. And the coronal, you can kind of appreciate the same thing again. Here's a different example, right? The inner mucosa of the trachea looks intact, but then in the submucosal, you can see marked thickening. The fat of the mediastinum is all kind of hazy. There are a couple of nodes. This is another example of, adenoid cystic carcinoma. Here's another one. They kind of look pretty similar, large endoluminal process, but then it's the way it grows. So if you're the mucosa, here's a pathologic specimen, they'll tend to protrude in, but if it's a submucosa, it expands the inner layer of the trachea. This is a cartilage, and it will tend to grow along circumferentially as well as protrude in. So a couple of examples of adenoid cystic carcinoma. As I mentioned, they originate in the submucosal region in the bronchial glands of the trachea. They are not related to smoking. Clinical findings are very similar for all airway lesions. They have, it's non-specific, it's cough, they can have hemoptysis. And on imaging, if you inspect the airway, you will see a lesion. And you may often see post-obstructive processes related to that, which is Either you get atelectasis, post-obstructive infection, and so forth. I won't go through too much of the, the clinical picture. You know more than me. Here's a different patient who was only 14 years old, and he was having abnormality, clinical symptoms for a long time. Finally, he had imaging, and you can see that he has an endoluminal lesion, as well as subsequently some lesions within the lungs. And this is a patient, classic appearance of bronchopulmonary papillomatosis. Here's another one. Again, these are all going to be usually young patients, and they'll have multiple lesions at different parts of the trachea that protrude into the lumen. And sometimes they can extend and grow into the lungs. And again, multiplanary imaging can kind of show the abnormality a little bit better. As I mentioned earlier, metastasis to the airway, to the trachea, is pretty rare. I've only seen one. This is the case that we had here. You can see that there is marked circumferential thickening of the trachea extending into the mainstem bronchi. A lot of this diagnoses are made at pathology and not, prospectively. As you can imagine, the findings can be non-specific. So but this is probably what we would see more often. And I didn't gather other images of other tumors like esophageal or thyroid, but certainly lung is one that will, like small cell is classic. It's central lesion in the mediastinum. It will grow into the airway and deform it and obstruct it, So these are certainly much more common than hematogenous mets to the trachea. So I kind of went through some common appearances of tracheal lesions. We can now turn our attention to inflammatory disorder. These are actually even more rare. There are multiple of them. They may be important for your boards. And every now and then you will see a case of this. And I think that if you know it, you'll look pretty good. And so we can review that. So I've broken down the tracheal inflammatory disorders into this chart. And the way I approach it is I look first at the location. If the location of the finding is at the thoracic inlet or very focal, then the classic diagnosis is going to be a post-intubation stricture, and I'll go over that. If it is diffuse, then I tend to look to see whether the posterior wall of the trachea is spared or involved. If it is spared, then I know that most likely the conditions that involve the cartilage, right, the horseshoe-shaped ring, is likely the cause of the pathology. And so I'm going to think of conditions that deform the cartilage. And the classic examples are relapsing polychondritis, which is a congenital condition. We don't see too much of it, usually in kids. And then tracheomalacia, which is what we're seeing more of these days. If it is circumferential, then the disease can be broken down into 3 categories. One is infection. And the classic example of infection is bacterial rhinoscleroma, TB. Fungal are very rare. I didn't mention sarcoid and inflammatory conditions like Crohn's, but they are even more rare, and the textbooks will talk about it, but I've never seen cases, but they are described in the literature. And then the other 2 are granulomatosis with polyangiitis, which we do see, and amyloid, which we'll see every now and then. So those will involve all the walls of the trachea. Calcifications and ulcerations may give you a clue. Usually amyloid may have calcifications with them. And if there's ulcerations, you may want to think about either an infection or granulomatosis with polyangiitis. Before we go to the inflammatory conditions, one thing about the airway that causes narrowing or stenosis is Saber sheath, and it is just recognizing an anatomic finding that we see. So as I showed you, trachea normally is a nice round structure, but in individuals who have increased intrathoracic pressures for a long time from obstructive lung disease, as the pressure is exerted on the airway, it remodels it instead of being nice and round to this sort of elongated structure. So saber sheath trachea is when the anterior posterior length increases and the transverse diameter of the trachea decreases. So when we see this, it just tells us that, yeah, this patient has probably obstructive lung disease. And that's about it. Not much to say about it. So as I mentioned, I like to break the diseases into whether it is focal or is it diffuse. If it is focal, the classic example is post-intubation stricture. So here's an example. You can see the trachea is okay, except that right at the thoracic inlet, there is narrowing. And if you look at the axial images, you can see that there is circumferential thickening. The normal trachea should be kind of about this big, but instead it is, the lumen is pretty narrow. And if we image the trachea above and below, it would be normal, just like here. So the trachea above is normal, below is normal, but right at the thoracic inlet, you can see this deformity and narrowing. And when you see this at the thoracic inlet, the first thing to think about is a post-intubation stricture. And as you know, that it is a complication of, usually trauma from either intubation or tracheostomy. As they inflate the balloon, it causes decreased blood flow to the mucosa of the trachea and eventually leads to, if it is kept in that manner for a long time, then it may lead to eventually fibrosis and granulation tissue. And because the balloon is just at the inlet, that's usually where we will see the abnormality and not the rest of the trachea. So post-intubation strictures tend to occur usually at the thoracic inlet. What about conditions that spare the posterior membrane? So as I mentioned, those are conditions that usually would involve the cartilage portion of the trachea. This is a normal trachea. When we take in a deep breath, as I mentioned, the posterior membrane bulges out. When you expire the air, the membrane will bulge a little bit in, but it should never become like this. So the cartilage allows the trachea to maintain its shape, particularly in expiration. But in some individuals, when the cartilage undergoes inflammation and is deformed, then in expiration, when there is increased intrathoracic pressure to get the air out, it is unable to maintain its shape and it collapses. And this is what we call a frown shape of the trachea, and this is tracheomalacia. And this is usually diagnosed when we do a paired inspiratory scan and a dynamic expiratory imaging. So as the patient is exhaling the air, we image the trachea, and if they have that, then then the images will appear like this. So tracheomalacia is excessive expiratory collapse of the trachea. The definitions have changed. I think today I should have changed it. It should be greater than 70% decrease in the volume of the airway. And the classic description is a frown-like configuration. Causes are usually from repeated trauma. And now there is some literature coming out. Now, it's interesting. Like when I started radiology, whatever, we never saw tracheomalacia, but the last 10 years, we're seeing so many cases, and we've kind of become the center for tracheomalacia in the health system. And so some articles have been written that one of the conditions that may be doing this may be the overusage of, not overusage, but usage of inhalation of medication. I think a large majority of the patients are on some sort of inhalers. And the study has shown that those inhalers are very acidic. And when you use them over a period of 30, 40 years, maybe you are changing the muscle tone and the cartilage tone of the airway over a long, long period of time. And maybe that has caused the tracheomalacia. So this is one of the theories, and it's published. So something to sort of think about. And you make the diagnosis by doing the paired inspiratory and dynamic expiratory imaging. And certainly you would be able to make that on bronchoscopy. Here's a different patient. You've seen x-rays, but you've never seen the airway so narrow. Clearly it should be much wider. So this airway is very, very narrow, but it's diffusely narrowed. And if one were to do the CT, they would see that the wall is thickened along the laterally and anteriorly, but the posterior aspect is spared, and it goes from top to bottom. And one of the things that would cause thickening of the airway but sparing the posterior membrane is relapsing polychondritis. If one were to do the dynamic expiratory imaging, you would see that this would be unable to maintain its shape and it would collapse like the other case. So here it is, a very long segment narrowing. It causes diffuse thickening, and you can see the thickening of the trachea. Again, another rare entity we see mostly in kids. It's a rare systemic disease. It's caused by recurrent episodes of cartilage inflammation. Wherever the cartilage is, whether it is in the ear, the nose, joints. And the way you make the diagnosis is you look for a thickening of the anterior and lateral tracheal walls with or without calcification, and it spares the posterior membrane. And you can prove this by doing dynamic imaging to demonstrate the collapse. As opposed to this condition where the posterior membrane is spared, but what you're seeing are these calcified nodules that are protruding into the lumen. And this is a condition in radiology we call an ant mini, which is like, a rare, but there is no differential. This is what we call tracheobronchopathia osteochondroplastica. So the cartilage has all these nodules that grow and protrude into the lumen. It is a benign condition. Etiology, we don't know. But what you will see are all these nodules protruding in, and the posterior membrane is spared because there is no cartilage there. What about circumferential thickening? Circumferential thickening, so as I mentioned earlier, airway findings are difficult to diagnose on plain film, but every now and then you may see, and on the lateral you can see that there is some thickening of the wall of the trachea. Certainly CT is the test of choice, and you can see that this patient has marked thickening of their airway, trachea, as well as there is some calcification, and it's extending into the right and the left main bronchi. And this is a pretty typical appearance of amyloid when you see thickening with calcification involving the trachea. Here are some other examples. The thickening can be smooth like that previous case, or it can be very lobulated or nodular, and it can be asymmetric. It doesn't have to be uniformly thickened, but it will be, of course, diffuse up and down the airway. Another one, and often it will have calcifications as well. You may see, as I described earlier, that a lot of these patients with airway abnormalities often present with post-obstructive processes. So here in this individual who has thickening and narrowing, he presented with post-obstructive infection. Again, on some sagittal and coronal reformat, you can see the irregular and kind of nodular looking thickening of the trachea with calcification. Some more examples of, amyloid. It kind of looks very similar if you see this sort of irregular thickening with calcification. Think possibly amyloid in the right situation. Here's another again, thickening circumferentially with calcification, very nodular and lobulated in its appearance. Amyloid, as you know, is deposition of proteinaceous material. We don't know the exact cause. CT, you will see this sort of smooth or nodular circumferential thickening causing narrowing. You may see or you may not see parenchymal findings, which may be nodules or reticular opacities. This patient, the airway trachea looks pretty unremarkable. It's hard to really appreciate anything. We do see some nodules in the lungs. There is this thing behind the sternum. So patient had a CT and they had some anterior mediastinal lesion. I think this was a benign finding. This was a cyst, a thymic cyst. But on the CT images, you can see that there is thickening of the trachea, which extends a little bit into the right main and the left main bronchi. On the lung windows, we can see that there are several nodules, some with cavitation. So this is an example when you put the two together, it is granulomatosis with polyangiitis. Here's a different patient. Usually it is subglottic thickening and narrowing of the trachea, but sometimes it can be diffuse. One of the characteristic findings is that you may see little ulcerations in the areas of thickening. Those individuals may have other accompanying findings. So this is a CT axial image of the face at the level of the nose. Normally you should have a nasal septum, but the nasal septum is destroyed here. And as I mentioned, you can also have nodules. Sometimes they can cavitate as well. So those are some imaging features of granulomatosis with polyangiitis. Here's a different patient, pretty significant circumferential thickening, causing some airways to be narrowed, extending into the bronchus intermedius as well. So granulomatosis with polyangiitis is a necrotizing vasculitis of the upper lower respiratory tract. On imaging, if the trachea is involved, which majority of the time it isn't, but if it is, we'll demonstrate circumferential thickening. You may see ulceration. Usually does not have calcification like amyloid. And as I mentioned, the posterior wall will be involved. And then we have another case here. Again, normal trachea should be nice and thin, but you can see that there is nice circumferential thickening. This is an interesting patient. He was 25 years old that came to North Shore. He had a history of testicular cancer, and so we thought about metastatic disease, but it's pretty unusual to have mets to the trachea. He underwent biopsy, and we thought that it's possible that he could have infection, so we did send the specimen for culture. It was in the differential diagnosis, and it did come back that he had rhinoscleroma. It's a rare entity, rhinoscleroma. So before and then after treatment, you can see that there is narrowing. And rhinoscleroma is caused by a bacteria. It is a descending infection, so typically it affects the nasal mucosa, and then the infection kind of comes down. Almost always seen in malnourished people. And I guess we can categorize him in that. He was from Mexico, didn't have a job, and he had a malignancy, and probably his, nutritional status was not great. And so he happened to have this. I've only seen one case of this, but good to know. And I think it's treated by antibiotics, tetracycline, I believe. And you saw the response. So I kind of went through tracheal diseases. And again, just to summarize, if you see diffuse tracheal disease, look to see whether the finding is focal or is it diffuse. If it's focal and at the thoracic inlet, think about stricture from prior intubation. If it's diffuse, look to see if the posterior wall is involved or not. If the wall is spared, then you're looking at disorders involving the cartilage. If it's circumferential, then break it down into infection. The two big ones are bacterial and TB, or probably very rare, but think about infection. And then probably the two most in everyday practice are going to be this granulomatosis with polyangiitis and amyloid. What about when the trachea dilates? So you can see that on this X-ray, the trachea is huge. The diameter of that is about the same size as the diameter of the vertebral body. So when the trachea dilates to that size, we call that tracheomegaly or Meunier-Kuhn syndrome. So this trachea, you can see it's greater than almost the size of the vertebral body, or by definition, if it's greater than 3 centimeters. These patients will often have all these little diverticula that arise from their airways. They may have bronchiectasis as well. So here's another patient with dilatation of their trachea, huge. And then on the CT, you can see again, dilatation with little diverticular formation and pretty extensive bronchiectasis, in both lungs. This is another congenital condition. We don't know the exact etiology, but we believe that it might be related to deficiency of the smooth muscle and elastic fibers of the trachea, which results in tracheal dilatation. And these individuals often tend to get recurrent bouts of infections. So that was, in summary, a review of trachea, which I break it down into, is it malignancy or is it inflammatory? And now we can go on to bronchi, which are the airways within the lung. And I've broken them down into two, one that causes endoluminal filling defects or abnormalities, or where those airways or bronchi are dilated, and then we call them bronchiectasis. When we see bronchi that have some sort of endoluminal lesions, the very first thing that we usually think about is a carcinoid. Other tumors can occur there as well, such as mucoepidermoid, Mets classically from breast, melanoma, renal. You can have hamartomas and mesenchymal tumors. And then, of course, very common, especially in the elderly in-house patients, are mucus plugs. So here are some examples. Here's a individual who had repeated bouts of infection in the same location, and so they finally did the CT scan to make sure that there was nothing obstructing. And you can see that here's the right middle lobe, medial segment, lateral segment, and there is some bronchiectasis from chronic bouts of infection. But right at the orifice, you can see this filling defect. And that's a pretty classic example of a carcinoid at the orifice of the middle lobe bronchus. And as I had mentioned earlier, often individuals with airway abnormalities don't come to your attention until late because they're often overlooked. Here's another patient, bronchus intermedius, left main bronchus, and you can see a nice filling defect with the post-obstructive process. Another example of a carcinoid. Carcinoids are well-circumscribed endobronchial lesions. They can have some punctate or diffuse calcification, and if we were to give contrast, which normally we don't, it will probably demonstrate this nice homogeneous enhancement. Carcinoids are broken down into typical, which is what we usually see, or atypical, which are rare, but they usually present with a much larger size, and often they'll have nodal disease. I won't go through, they arise from the neuroendocrine cells. I've never seen paraneoplastic syndromes, but certainly it is mentioned and you should be aware. Usually it's the GI tumors, carcinoids may present, but lungs I've never heard, but it's theoretically possible. The important thing to note is that if one were to do a PET CT, these lesions have very low metabolic activity, and so you may see no uptake of these lesions. And if you suspect that it is a carcinoid, then you may want to do an octreotide scan, and if that lesion is hormonally active, then it will demonstrate intense uptake. So sometimes patients who we suspect of having carcinoid will get a PET followed by an octreotide scan to help with the diagnosis. Here's a different patient at the carina, left main, and then right main bronchus. You can see that there is a filling defect and resultant post-obstructive process. In the abdomen, this patient had a renal tumor. So they biopsied, and this was a metastasis from renal cell carcinoma. And sometimes we'll see this as well. This patient presented with this large consolidation in the left lung. X-rays are very difficult, to make anything out of. But on CT, you can see that there is this structure, elongated structure, which when we fished it out was a prune pit that was obstructing the airway and causing post-obstructive infection. So foreign bodies are something else that we see as well. And then, of course, if those bronchi dilate, then we call that bronchiectasis, and we give a different name, but it's not that important. Cylindrical, or when it's tubular dilated, and when you take axial images, it will appear as such. Varicoid, very irregular shape, or kind of saccular looking. Not that important, but we've given them names. And by definition, bronchiectasis is irreversible thickening and dilatation of the bronchi. It's important to note that when you read a CT scan and the patient has active infection and you can see opacities and the airways are dilated, that we refrain from using the word bronchiectasis. Bronchiectasis is irreversible thickening and dilatation. In an acute inflammatory process, the airways may transiently appear thickened and dilate. And in the literature, that's been called pseudobronchiectasis, or best not to say anything. But once the process resolves, and if you do the scan and those airways, if they have not returned back to normal and they persist as dilatation, then you can certainly call them bronchiectasis. Of course, CT is the best way to diagnose bronchiectasis. Bronchiectasis are caused by many. On CT, it's very hard to come up with the etiology except for a few handful of conditions. You would need a good history, asthma for ABPA. Did they have childhood infection? Do they have congenital immune deficiency stage? Do they have systemic diseases? And then, of course, when we review scans, we try to determine the distribution. Is the bronchiectasis in the upper lungs? Then maybe it is CF. If it is in the central regions, then we think about the two classic CF and ABPA. If it's in the middle lobe and lingula, we tend to think maybe it is from MAC. And you look for ancillary findings to give you clues, and sometimes you have to do a lot of blood tests and or genetic studies to come up with the exact diagnosis. So I'll just show you some examples. So here's a patient on the axial images. You can see normally the airways travel with the pulmonary artery and they're paired structure. They should be the same size. But you can see that here's the pulmonary artery, the white dot, and the airway is markedly dilated. So this is thickening and dilatation of the bronchus, so it's bronchiectasis. This has been referred to as a signet ring sign. So this is bronchiectasis throughout the lungs. And if you see this in a young patient, and I'm sure you see, because I think at Cohen's we have a lot of individuals that have this, and the distribution is upper. This is cystic fibrosis. As opposed to this condition where you're seeing the bronchiectasis in the right lower lobe, but on the X-ray you can see that their heart is apex is pointing to the right side. Their liver is on the left. You know, it's a correct label. So all their organs are switched. So when you have situs inversus and bronchiectasis, we will tend to think that this is Cartageners, and we may want to check their sinuses and mucociliary function as well. A different patient, we can see that there is like this lobulated opacity or consolidation in the left mid lung. In the right lung, we can see some tubular shaped lucencies. On CT, you know, those things look like they're bronchiectasis. Intervening lungs look normal. So this is a very patchy areas of bronchiectasis, and then they have some consolidation. And in the right, and then if you see this picture where you have patchy areas, then you may want to ask, and if the history states that they have asthma, then this is a diagnosis of ABPA. Sometimes on an X-ray, you may see this sort of tubular shaped opacities, and that has been referred to as the finger in glove sign, which represents mucoid impacted dilated bronchi. So here it is, bronchiectasis. Some of the dilated bronchi are filled with mucus, and another one here, some have nothing, some have mucoid impaction. And I won't go through the clinical picture. You know that you know more than me about that, but this is a patient with asthma and ABPA. This individual, you can see, also has bronchiectasis throughout their lungs, but it's predominantly in the middle lobe and lingula, and they're very thin, and if they're elderly, you know, and of course we see a lot of this here. This would be a MAC infection. So classic distribution is middle lobe and lingular. It doesn't have to be, but if you see that, then it helps, and you may see some tree and bud opacities as well. Okay, so that in summary was a little review of the trachea and the bronchi, and then the final part is the small airways, and involvement of them or inflammation of that is termed bronchiolitis. Bronchioles are airways without cartilage. They're very, very tiny. So trachea will divide until it's a terminal bronchiole in the secondary lobule. Beyond that, there is no bronchiole, but it gives rise to a respiratory bronchiole, which gives rise to alveolar ducts. So here's a picture illustration. Here's a trachea and bronchi. They divide. Lung, as you know, is made up of numerous secondary lobule, which is the smallest functional unit of the lung. The airway that comes into that lobule is the terminal bronchiole. Beyond that is the respiratory bronchiole and then alveolar ducts. And so here it is. So airways divide. Here's your secondary lobule, terminal bronchiole, respiratory bronchiole, and then alveolar ducts and sacs. This is where gas exchange occurs. When you have inflammation of these structures, respiratory and terminal bronchioles, we call that bronchiolitis. And that is broken down into two main categories, whether you have proliferative bronchiolitis or you have obliterative or fibrotic or constructive bronchiolitis. If it is proliferative, then the classic examples are either it's caused by infection or hypersensitivity. And then, of course, there are other rare things like respiratory or diffuse panbronchiolitis. As opposed to fibrotic or obliterative bronchiolitis, the history will guide you as to why it did that, and I'll go over that in a minute. What does bronchiolitis look on the CT? If it is proliferative, then you're going to see two main findings. You will see centrilobular ground-glass nodules, and then you'll see branching tubular opacities, or what we refer to as tree and bud. If those distal airways are completely obliterated, and that's what you're dealing with, is a constrictive or fibrotic obliterative bronchiolitis, then those are not going to be visible, but what you will see is an indirect sign of it, which is mosaic attenuation or air trapping. Tree and bud, as you know, are these sort of branching tubular structures. They can occur everywhere, but they're best visualized along the peripheral portion of the lung. They indicate that those airways are either impacted with mucus or infection. And, you know, they're like what we're getting to in the spring, which is this little budding of branches. And so you can see this sort of branching tubular opacities in the lungs. And we see a lot of this, and oftentimes if you don't see any of the findings and it's scattered, it probably is just mucus impacted airways. And here are some more tree and bud opacity. But if you see tree and bud opacities like here branching, but then you see a nidus of other opacities like this in multiple portions of the lung, and the patient comes in with fever and cough, then you could probably say that this patient has pneumonia and he's coughing and he's spreading it to himself and everyone, which is probably more important in this condition. As you know, this is a patient who has this cavitary lesions in the left upper lobe. You can see that they have tree and bud opacities. And when you see this picture without even any history, the first thing to think would be that this patient has reactivation TB with endobronchial spread. And of course, you know, you put everything together, you know, and yeah, this is a patient with that condition. So this is, when you see this, you want to put them in isolation because they're infectious to themselves and to others. Mosaic attenuation represents alternating areas of lucency and increased attenuation of the lung. Often it can be hard to tell when to call this. So whenever we describe mosaic attenuation, what we're saying is that this lucent or the darker areas are abnormal, and the hazy or opaque portions of the lung are normal, which is different than when we describe something as a ground glass opacity. Ground glass opacity will appear as an opaque lung. And so the question is, how do you differentiate whether you're dealing with ground glass or the darker area as being abnormal and we're calling it mosaic attenuation? So what you want to do is you want to look at the interface between those two areas. And if you can identify that the interface is very sharp and anatomic, geographic in its appearance, then it is very likely that you're dealing with the lucent area as being abnormal. So here's an illustration. And if you can think now on the next image, these are all the lobules. And as you know, the lobules, the walls of the lobules have sharp edges. So you will have entities that affects the lobules. And when it does that, it will be sharp border forming. So you can imagine the airway or the blood vessel that's supplying this area. If it's affected, then that area will appear dark and the other areas will remain opaque. The two main conditions that will give you this are airway disease, which is what we'll talk about, and of course vascular or chronic thromboembolic disease, which we won't touch base today. How does it look on imaging? So when you look at the images, you can see that this is a little loosened, a little bit of opaque. And if you look more carefully, you can see that the borders are kind of sharp. So it kind of gives you a hint that maybe now we're dealing with maybe a picture of mosaic attenuation, and that in fact is darker areas that are abnormal and not the ground glass, because the differential diagnosis is very different. If you find that it is harder for you to tell, then you can do an expiratory scan to sort of accentuate this finding. Now, if you look at the case here, whenever there is ever ground glass opacity or alveolar filling process, it will tend to diffuse throughout the lung parenchyma and you will never see those sharp edges which I showed you, and I'm going to show you some more. It will just tend to kind of, go everywhere, right? Nothing is sharp here in any of this. As opposed to this patient where you see the lucency and the opaqueness, you can see how the borders are very sharp, right? Very sharp borders. So you know that this is normal lung, and this is abnormal in this patient who has extensive bronchiectasis, and probably this is all air trapping from a lot of plugging of the airways. So when we talk about mosaic attenuation, it is the darker lung, or the loosened lung that we're dealing with. And the two main causes are airway disease, small airway, or vascular. Today we'll talk about this. And the classic example is obliterative bronchiolitis. As I mentioned earlier, sometimes it can be hard to tell whether the dark regions are abnormal or the ground glass are abnormal, or whether you're dealing with airway disease or vascular disease. So what one can do is you can do what we call paired inspiratory and expiratory. So you have the patient taking a deep breath, hold it, and scan the chest. And then you do another scan where you tell them, take a deep breath, completely expire the air, hold it, and you image. So when you're taking a deep breath and you let it out, the lung, like a balloon, will give the air out and it will become opaque. But if you have areas, small airways that are affected, air will go in, but it won't exit. And so those affected loosened areas will remain the same in size, or it may enlarge and demonstrate air trapping. And that may help you determine that you're dealing with air trapping as a diagnosis. I also tend to look for other ancillary findings. If anyone has airway disease, look for other findings like bronchiectasis, tree and bud, mucoid, and history, which is probably even more important, because there are very few conditions that will give you this, such as someone who has had transplantation, they were involved in some sort of inhalational condition, and so forth. So in the right clinical setting, you may want to think about this condition. Vascular disease, look for other conditions such as, almost always is going to be caused by thromboembolic disease. So you're going to look for big PA, look for filling defects, and right heart enlargement. So here are some examples. Inspiratory, expiratory. Look at the trachea always. When you're taking a deep breath, the posterior membrane is straight or bulging out. In expiration, it bulges in. And you can see that small airway disease can often be missed on inspiratory scan, but it will certainly be evident if you do the expiratory scan. And so you can see this opacity and then areas of lucency, opaqueness, and lucency. Again, very sharp borders, suggesting that you're dealing with air trapping here. Some examples, here's a young individual, inspiratory scan. You can kind of get the hint that, yeah, the left lung is a little bit loosened. But when they expire the air, you can see that the lung becomes a little bit more opaque because air is coming out. But the left lung remains dark or loosened. And when you see a very unilateral hyperlucent lung and it is small, one of the conditions that we talk about is Swyer-James syndrome or bronchiolitis obliterans from an old childhood viral infection. Here's a different patient. This patient underwent a left lung transplant. Only the left lung was transplanted. The right is still abnormal. And on inspiratory scan, scan looks okay. Maybe there are some areas of lucency, but on expiratory, you can clearly see the demarcations of opaque lung, loosened lung, opaque and loosened, right? Mosaic attenuation. And this is a picture of obliterative bronchiolitis in a patient following lung transplant, which is not uncommon in this group of patients. And as I mentioned earlier, if you don't suspect this condition, then it is likely, and if you just order an inspiratory, you are likely to miss it. Like in this patient who had an inspiratory scan, it's hard to really say too much. But on expiratory scan, you can see that, yes, there are areas of lucency and opaque lung, lucency and opaque. So it accentuates the air trapping. And so this was a young woman who was trapped in her house when a fire broke out for several hours. And this is another cause of bronchiolitis from smoke inhalation. We kind of we took a little journey through the airways from the trachea. We went through conditions that affect either narrowing caused by tumor or inflammatory conditions, or dilatation like tracheomegaly. We reviewed bronchi, and then we spent a little time on distal airway diseases. So with that, I'll end. I'll take any questions if you have any questions. And thank you very much, everyone. And, you know, I appreciate the fellows a lot for everything. So hopefully you learned. If you have any questions, please, you can ask me now or later, whenever. Is anyone there?
That was
We're here.
fantastic, Rocky. We appreciate it.
Hope I didn't put anyone to sleep. It's a lot of images. Hopefully you just enjoyed. Hopefully some of those will be on the boards for the fellows, you know. It may help
That
you.
was wonderful. Thank you. Thank you so much.
Oh, you're welcome.
Amazing review, Rocky. Really very thorough and logical and beautifully presented.
No,
Thank
that's too kind of you, Effie. Thank you.
Oh.
And you know, I can if someone wanted to have this and review it, it's always there. The file is very large, so it'll be hard for me to send it to you. But when I come to the hospital, I can put it on the flash drive and give it to you guys. If you ever wanted to review it, or you can ask me and I can always share it again.
Maybe putting it on the shared drive on OneDrive, Rocky? I don't know if it would go on OneDrive.
Yeah, you can let me know. I don't know. I'm not a computer savvy, so if someone can tell
Sure.
me which shared drive or how to get to it, to walk through it, then I can do that, you know.
Okay.
Sounds
awesome.
great. Yeah,
Okay.
thank you so much.
Okay, you're welcome.
Thank you, Rocky.
Okay,
All
all right. Thanks, everyone.
All right.
Okay.
Thanks, Rocky.
Okay. Bye-bye. Bye.
Bye.